Okay, hello everybody, and welcome to workshop number 10 at the Global Mental Health Summit, MHPSS from local to global emergencies. My name is Iken Nazwike, and it's my pleasure to be your host today. Over the next 2.5 hours, we'll be taking a look back at the progress that's been made since the Mind the Mind Now conference in Amsterdam in 2019. We'll be exploring the value of integrating MHPSS in emergency response. And just as yesterday, we heard from our Italian colleagues as to what the future holds for the next summit in Italy next year. We also will be looking ahead at how we can amplify the work that's currently being done to achieve even greater MHPSS goals. And we'd like to do all of that with you at home and with the live audience that we have here in the room. So if you haven't already, there should be a QR code that's appeared on your screen. Please scan that. And then you can ask questions via Slido. You can submit questions. And if you'd like to submit questions via social media, then please use the hashtag, which is MindRightsNow. Okay, I am joined in this session by my co-host, who is the co-chair, lots of coing over there, of the Interagency Standing Committee MHPSS Reference Group, and that is Carmen Valle Traballero. Hi, Carmen.
Hi.
Welcome.
Good morning, Ikena. Good to see you.
Carmen, as a professional in the MHPSS sector, and also someone who went to workshops yesterday and you saw the plenaries, what are you hoping to achieve from today's session?
I think I really want to see a bit of an overview of what's been happening since Amsterdam in the mental health and psychosocial support in humanitarian context. And I would also like to show how much we can learn from the work that is being done by colleagues in mental health and psychosocial support from the humanitarian into other sectors.
Yeah. Okay, well, let's hope that we can make my co-host happy and do that today. Before we get started, though, let's play a short pre-recorded video message from the Acting Assistant Secretary General and Deputy Emergency Relief Coordinator at the UN, OCHA, and that is from Ramesh Rajasingham.
Excellencies, ladies, gentlemen, colleagues, thank you to the Government of France for bringing us all together to take a good, hard look at our efforts to provide mental health services to crisis-affected people. All of you know how important a person's mental well-being is to help them withstand and recover from a humanitarian crisis. The COVID-19 pandemic indeed brought home the importance of mental health and psychosocial support. It reminded us that those most at risk are frontline healthcare workers, older people, adolescents, young people, people with pre-existing mental health conditions, and those caught up in conflict and crisis. We know this, yet the truth is that what we are doing is still not enough. We dispense medicine to treat physical wounds and deliver food to address hunger, but too often we don't do enough to respond to mental health needs. I recently traveled to Haiti in the aftermath of the tragic earthquake there. There, I met Marie Rose, a mother of 4, who had lost a 2-month-old baby in the earthquake. She had not even had time to process her grief, spending instead 4 hours each day walking to find food for her remaining 3 children. It's unimaginable situations like these that we need to address and prevent. We are taking some steps to address gaps in our response. The Joint Interagency Call for Action of December 2020, endorsed by OCHA and other UN agencies, reaffirmed the need to do more. We have the guidelines on mental health and psychosocial support in emergency settings, developed by the Interagency Standing Committee, or the IASC. They are indeed the gold standard and available in 16 languages. Last year, humanitarian coordinators regularly monitored the level of mental health services support in the humanitarian response plans. This prompted more countries to incorporate it this year. And early this year, we integrated mental health and psychosocial support in our guidance to humanitarian coordinators and their teams in country. We're also proud to host the Mental Health and Psychosocial Support Reference Group in the IASC, which, under the leadership of the World Health Organization and the International Federation of the Red Cross and Red Crescent, which comprises more than 60 organizations as well, is doing tremendous work. We now have more than 50 technical working groups in various countries that ensure mental health services form part of our emergency response, for example, in Bangladesh, Burkina Faso, Ethiopia, Kenya, and Nigeria. All of these initiatives are important and well worth doing, but they are not enough to keep up with increasing needs. And I would like to remind donors that the cost of not investing in mental health services is, as you know, tremendously high. Mental well-being affects every aspect of people's lives. While we work to do our part, governments must also support and care for those affected by mental health conditions and protect their human rights and dignity. If not, I fear the children of crises could end up paying the price, a generation lost to deeper wounds. Thank you.
Yeah, powerful words there. And it's so easy to get numb to some of the personal stories, the anecdotal evidence, but I think we have to do our best not to.
Absolutely.
Carmen, someone a lot cleverer than me once said that it's terrible to let a good crisis, never let a serious crisis go to waste. Do you think COVID actually represents an opportunity for us to integrate MHPSS in emergency response more widely?
I really think so. I really think colleagues who have been working in humanitarian responses all over the world see and feel how much our sector is gaining attention at the moment and how much focus there is on mental health. And I think it's because suddenly every country has felt it very personally. We are in a crisis and suddenly we can connect with what we've been saying. When a crisis comes, the mental health and well-being of those affected is essential to take care of. And suddenly everybody has felt it in their own skin, in their own lives. And I think this is why we're gaining such a momentum, and it's an opportunity to transform indeed.
Okay, yeah. Well, that's optimistic. Let us let's get started with the workshop proper. Today, we split up the workshop into 4 different sections. Achievements since Mind the Mind Now, the anecdotal evidence of key areas of transformation for MHPSS in recent years, ongoing action through illustrations of some important projects that are currently ongoing, future action, that look ahead that I mentioned in the introduction. What do we need to do next? And there will be a break in the middle for us to be able to reflect on what's been discussed. First of all, let's run a video which puts into perspective what's happened since Amsterdam 2019, the Mind the Mind Now conference. A look back.
In humanitarian crisis, I do believe that MHPSS is a matter of life or death.
And we need to break the silence that still oppresses so many.
Neglecting this problem undermines the recovery of individuals, communities, and nations.
To come out of my experience, it was so painful because I thought I had no reason to live.
Constant feeling of that constant hunger of not knowing when the next time I would eat.
No wonder I can see his eyes that he was so sorry he couldn't do anything for that young man. He had to go and help other people who had a chance to live.
If I would be now in Syria and say like I need psychosocial support, the people gonna look at me really weird way and ask me a question this way: are you crazy?
Yet in many cases these conditions are ignored or trivialized despite the fact that they risk leading to serious long-term consequences.
The issue of mental health care is still considered a taboo.
We have to connect government with community.
The main barrier for implementing or taking our efforts forward is lack of political will and funding.
The majority of people, they can recover very well after these disasters if we manage to provide the adequate social support for them.
The people who see me as like a traumatized refugee and tell them, oh, look at me now. I'm no longer just a victim. Instead, I'm a person with skills and expertise to support my community.
The fight for global equality for mental health has only just begun.
To be very frank, you need champions to bring this on the political agenda.
80 million children are living in war zones today that need psychosocial support right away.
To see people from many different organizations coming on board for this agenda. So it's a big thanks to the Netherlands for creating this moment.
Put mental health and psychosocial support first, all the time, everywhere, for everyone.
This conference makes me more hopeful about the future of mental health.
I'm really pleased that finally people are actually talking the language that people need.
Educating people and creating awareness again, I think very important, and that's what I will try to do when I get back.
It should be a common sense that we spend time and money in this topic.
As a priority, not something that's done later and not as a backseat issue.
And we can't forget anyone anywhere across the globe. We really need to invest in mental health.
Yeah, good. Now, I think you get a little bit of a sense of it from that video, but I remember being there and feeling a genuine excitement among the audience. People there's this Dutch sound that Dutch people make, hair, which kind of means finally, people getting it. We're talking about MHPSS at the level it needs to be talked about. Okay, but as that video showed, the Amsterdam conference resulted in a rich set of recommendations and commitments, but the last 18 months have also shown that there is always a need to adapt, even in the humanitarian sector, which has a lot of MHPSS expertise. There were pre-existing MHPSS programs that had to be transformed. And to talk a little bit more about that transformation, we've got a new speaker, and that is joining us virtually. We have Dr. Mohamed El Shazli. Doctor, are you with us? Yes, I can see you on the big screen there with a lovely background. Thank you very much. Yeah, we of course spoke as well. I remember in Amsterdam. It's good to see you.
Exactly. Good to see you too. Virtually this time, yeah.
Yeah. So what was it like? Just take us back to have a summit dedicated to work that had been your bread and butter, that you'd been doing day in, day out, and all of a sudden there was this summit dedicated to it. What was that like?
Well, I think, it feels great, huh? Now more than ever before, I think this is the level of attention and advocacy for mental health that we all need. Huh? I'm very happy and proud to see that mental health is being addressed and discussed at such a high level, and also happy to see this level of commitment from policymakers growing year after year. You know, from London to Amsterdam and now Paris. Having the summit this year as well, framework focusing on the dignity of people with mental health concerns and promoting the rights is a key aspect in mental health service delivery nowadays, and this is something that we really have been standing for years and years. So yeah, happy to see all this happening at one day. Yeah.
And then of course COVID hit, and how did that impact your work?
Since the beginning of this pandemic, I have been working on mental health in almost 6 countries. And across these countries, there is some common findings that mainly related, to the increase in the mental health needs among all groups of the population, and also the limited resources, especially in relation to the frequent interruption of mental health service. What I would say that was very interesting to find early in response to the pandemic is that some low-resource countries, some less developed countries, they acted somehow better in response to the pandemic compared to countries with very well-developed health systems. And it seemed this somehow was related to the institutional experience in these countries in responding to similar pandemics before. So them somehow at the beginning to say smoothly in the shock and panic phase that everyone struggled with. Of course, later on, the pandemic was overwhelming everywhere. Yeah.
Yeah, we were talking about it at dinner yesterday even, weren't we, Carmen, about in some countries, people being further ahead in terms of early warning systems and making them inclusive even, and doing innovations that aren't actually in place over here yet. Okay. Before I'm going to ask you another question, Doctor, but just a reminder to the online audience, please. If you'd like to contribute and ask questions, do go to slido.com and insert the code 880399. Okay, slido.com 880399, and then you can actively participate in you can see it on your screens as well, or you can scan it on the screen. Doctor, do you have a question for the doctor? No. Do you see a different attitude towards MHPSS since COVID?
Yes, and I think Carmen already pointed to this issue. I would like here to highlight two aspects. And the first one is the pandemic made mental health the concern of almost everyone. Before that, mental health was the concern of a smaller proportion of people who are affected by adverse situations. And usually this takes place very far in the low-income countries. And most of the people around the globe may not be very well aware or familiar with this. But now, with this pandemic, the mental health became the concern of almost everyone on the globe. Everyone is worried about his own or her own mental health, about the mental health of their own children, their own parents. And this helped a lot to bring the mental health into the top priority of the public health agenda, which, despite the tragedies associated with the pandemic, but it's a great political win to bring more attention and focus to mental health. The second aspect of this is, I think with time, countries realize the importance of having emergency preparedness and response planning. I guess with time, the care system realized, even with source care system, still if you don't have a preparedness plan in place with the complexity of this pandemic, the whole situation can be very challenging. And I could see this in many countries now, that they are taking very leading initiatives to develop emergency preparedness and response planning. And I could see the Interagency Standing Committee now, in collaboration with WHO, they released the framework for the mental health emergency preparedness planning. And I think this is a great step that would help many countries across the globe in being very well prepared for future emergencies. Similar to this, but even hopefully with the smaller scale emergencies as well.
Very clear. Thank you very much, Doctor, for joining us. Okay, to help show people the value of integrating MHPSS, of course, it's helpful to see, okay, what are the results that have been achieved? Let's have a look at the recommendations that came out of Amsterdam. What's happened to them? Have they been met? Have they been achieved? Have they been exceeded? The progress has been mapped, and Carmen here is going to help present the results of that, together with from the WHO, Dr. Fahmi Hanna. Dr. Hanna, are you online and available to talk with us? Perhaps not. I don't know. But Carmen, you can begin.
Yes, indeed. And we can maybe show, we've put together a small visual just for people to be able to follow, and we're going to see it in a minute. As you were saying, in Amsterdam, there was a lot of reflection on what needed to be done, and that was done around 6 or 7 areas of work, just to be very clear on the specific actions that were needed. So groups came together and discussed on these areas, and what we've done now, preparing to this summit, is ask again those actors. So you recommended this 2 years ago. How have we done? How has been going on in terms of achievements? And we've mapped that in an infographic that we will share online.
Keep on the mic, otherwise.
Sorry. We will share this infographic online afterwards, so people can read it more in detail. But today we only want to show these initial results that you can see. These are the areas where we discussed in Amsterdam. So we had colleagues discussing about MHPSS in public health emergencies, investment, research, gender-based violence, and other aspects. So actually, my colleague Fahmi Hanna is going to be able to guide us a little bit into what's been achieved in the first 2 areas, in public health in emergencies and financing for MHPSS. So Fahmi, over to you.
Thank you very much, and I hope you can hear me now. Perfect, thank you. And if we can go to the first slide and the achievements, please.
so there's no so much test in the screen, so just you can talk to this one.
Sure, and about MHPSS and public health emergencies, one of the key achievements was the launching of the rapid deployment mechanism. This really served humanitarian emergencies.
Okay.
Supply created even more demand, and we saw countries that did not have a mental health and psychosocial support coordination mechanism before recognizing the need and requesting surge support in establishing. Received requests from countries such as Djibouti, Chad, Guyana, Peru, and many others. The number of countries with functional mental health and psychosocial support technical working group increased from 23 countries in 1 year to become more than 55 countries. MHPSS was recognized also in multilateral plans, for example, and also in the UN agencies, governance bodies. For example, MHPSS was included for the first time in humanitarian response plan, in the COVID-19 strategic preparedness and response plan, and the WHO member states in May 2021 recommended MHPSS scale up and monitoring indicator for MHPSS in countries every 2 years. We also now have technical resources in this area in public health emergencies that are wide range and available in numerous languages that can be used in this one and in future public health emergencies. However, a key limitation, colleagues, we saw when we do scale up human resources is that we actually need to continue building the capacity of additional human resources. We need also more diversity. The roster we have need to be scaled up with more experts who are French, Portuguese, Arabic, and Spanish speakers to build the capacity of the existing roster to include topics such as monitoring and evaluation and preparedness. We now know where we can invest when it comes to investing in MHPSS. We have a costed minimum service package for MHPSS developed, and ongoing testing is happening in Ukraine, Nigeria, Iraq, and other countries. Case studies on investing in mental health were developed with examples from countries such as the Philippines. The key limitation is that the investment is not happening. Government expenditure on mental health services is still below 2.5%, and only less than 20% of countries had their COVID-19 MHPSS activities fully funded during the response, with a wide gap in human and financial resources in this area of work in all countries. Really, all partners still need to work with OCHA together to make sure that an indicator for mental health and psychosocial support is included in the financial tracking system in humanitarian emergencies to understand how much is being spent on this area. Thank you, and over to you, Carmen.
Thank you so much, Fahmi, and I couldn't agree more with the points highlighted, especially in the need to continue in building the funding and supporting those initial very strong steps, deploying people all over. The other areas that we can see in the infographic have had similar moving forward. All of the areas we can see that something has happened and has been moving forward. So, for example, we've seen more and more technical guidelines developed for some of these areas, including gender-based violence, including the integration of persons with disabilities in our programming as MHPSS experts, and including also for people on the move, for communities of migrants and refugees. So in all of the other sectors that you can see there, we've developed either technical guidelines or they're being developed at the moment, and always in consultation with the broad MHPSS community. We can also see a lot of, in these last couple of years, there's been a lot of integration of gender-based violence and MHPSS. Our colleagues in the gender-based violence community has been developing tools to see how we can better integrate MHPSS, how they can take the MHPSS considerations of their work into account, and we are trying to do the same and think how can we be better as mental health professionals in supporting our colleagues and that are contributing to gender-based violence. So it's a mutual relationship that is very healthy. When it comes to research and innovation, we have more and more evidence of what works. What can we implement at country level that is useful, that is supporting the mental health and well-being of the communities we help. So that evidence keep on building, but we also are looking into what do we need to prioritize in terms of research. So all of those results are there since Amsterdam, and finally a very big effort for inclusion. which is one of those areas as well, is how can we make the materials that we do inclusive and in inclusive formats? How can we make sure that organizations of persons with disabilities are present in our response and have a central place? So all throughout those areas, we see that, yes, we've been doing since Amsterdam. We still have a long way to go, but at least we all feel that they were not all words very nicely said in a conference. I think we're really acting into trying to do our accountability part in moving forward from the Amsterdam recommendations.
Yeah, fantastic. Thank you very much. Thank you to Dr. Hannah as well. Lots of very thoughtful new perspectives there, and more cause for optimism, tools. And I saw joining us in the audience here, Peter Ventevogel, nodding vigorously when Dr. Hannah was talking about the need to scale up and do that with lots of diversity, variety of roles and languages and so forth. And something Dr. Hannah talked about, the increase in interest at country level for the surge support, Dutch surge support. And that's something we're going to explore with our next speaker. We're now going to kind of segue into a section with 3 different panel discussions to highlight some of the key areas of transformation in the MHPSS field since Amsterdam. We'll be talking about rapid deployment. Of course, the COVID-19 response and emergency preparedness. So 3 panel discussions, and the first one is on rapid deployment. And I'm joined now by, or hopefully, if the internet gods help us, work with us, Sylvie Herkman from the Netherlands Enterprise Agency, and that is the body coordinating the deployments of MHPSS experts, and is really the driving force, together with the reference group, behind Dutch surge support. Hello, good morning, Sylvie.
Good morning. How are you?
Doing okay. Pleased you're online and that we can hear you clearly. Tell us, Sylvie, what is Dutch surge support exactly? Just sketch it out for us.
Yeah, sure. So it's what Dr. Fahmi Hanna has already mentioned. It is the rapid deployment, rapid response mechanism for mental health and psychosocial support in humanitarian crisis. And we have been set up right after the last summit in Amsterdam. So we started at the beginning of 2020 in response to this growing need for psychosocial support during emergencies. And our program is funded by the Dutch Ministry of Foreign Affairs and implemented by the Netherlands Enterprise Agency. And we work a lot with the co-chairs of the IASC reference group on MHPSS. In order to implement this program, we have standby agreements with several humanitarian organizations such as WHO, UNHCR, IOM, UNICEF, and Action contre la Faim. And these organizations can request support from our response mechanism on MHPSS. And we have a database of qualified MHPSS experts from all over the world who are interested in short-term deployments. And so we respond to these requests from international humanitarian organizations, and we provide support for a couple of weeks up to a maximum of 6 months. And currently we have a focus on interagency coordination of national or subnational technical working groups on MHPSS. And apart from that, we also train experts on our roster, especially in interagency coordination on MHPSS, to create this new pool of qualified experts who are ready to be deployed all over the world.
A lot has been achieved since the beginning of 2020, and it sounds from what Dr. Hannah was saying as well, it's been popular, it's been effective. But have you just sort of scratched the surface of the potential here, or is this it, and we just need to get more people on board, more people interested?
Yes, both. So we started last year with the intention to do at least 5 deployments in 2020, and we ended up deploying 13 experts. And so far, as Dr. Fahmi Hanna was also mentioning, we've deployed up to 25 experts until now. So it's been quite popular, and it also, we're currently focused on interagency coordination, but there's so much more needs in this field of MHPSS, and yeah, so I think it's just a start, and just to give you some idea, we've started in South Sudan. That was our first deployment, but we've supported a lot of different emergencies up to now. So from Kenya to Afghanistan to Mozambique, Haiti, and also even some regional supporting positions. So in the Caribbean, for example. Yeah, just to give you some idea of what we've been doing so far.
Thank you very much for that. And we're actually going to talk to two speakers who were actually deployed by DSS. Before we do that, though, there's an interesting question's come in via Slido. Why do you expect short-term deployment of, for instance, 2 months to help in situations where there is a structural lack of mental health capacity?
It's a very good question, and we are only here to fill gaps. So we're not here to deploy people for a very long period. So we're talking with the humanitarian organizations that need support from us, and we explain them that they need to look for funding to continue these roles. And that's actually what we've seen in the past with quite some deployments, is that after our short-term gap filling deployment of a couple of months, the organizations have seen the need for these roles and have tried to secure funds to continue these positions. But as a rapid response mechanism, we're not here to support different roles for a very long period.
MHPSS experts who the important interagency work. We have both of them online, Teresa Ombalo and Sarah Rizik. I apologize if I pronounce your surname incorrectly. Carmen, how did I do?
I think okay.
Okay,
at least
well,
I do the same.
We'll find out in a second. Teresa, let's go to you first. Sylvie just described you as an MHPSS important gap filler. Is that how you see your role?
Most definitely. I think also given the 2 deployments that I've been on, the first one, my very first deployment in Ethiopia, and then my second deployment in Kenya, I would see myself as a gap filler in the sense that I worked together with colleagues to kind of bring partners together, partners who are providing MHPSS in their own capacities, but then not working together in a group to deliver as one, or so to speak. So yes, I would see that. And then also the different initiatives that we started in Ethiopia and also in Kenya have taken root. And I think those 2 working groups are going on quite well. In Ethiopia, for example, when I arrived right after the emergence of COVID, we made sure that MHPSS was made as a sub-pillar in the case management response under WHO, and we worked with different institutions, including academic institutions, to just make sure that people that were being that were being put under mandatory quarantine were receiving the psychosocial support that they needed. And also much later on, towards my 5th or 6th month, when now we were talking about home-based care, when the institutions were getting overwhelmed, just making sure that there were still experts who are reaching out and providing MHPSS for persons in home-based care.
Thank you very much. Thank you very much. Sarah, is Sarah online? Perhaps you can share how your experience differs from Teresa's during your deployments.
Yes. Hi, hello, everyone. So it sounds similar to the deployment of Terry, my colleague. Maybe the difference is that I worked remotely from Tunis to support Libya mission, and the working group I had to really invigorate, I would say, the MHPSS technical working group on site, understand more who's doing what where, so the mapping of services, the analysis of the situation, and support the Ministry of Health in centralizing and then disseminating the information to all of the partners, as well as establishing links across partners, and similar to Terry, to I would say transfer the knowledge and resources related to MHPSS in times of COVID, so all the adaptation that was necessary. So I would say quite similar, but all of the work was done remotely since I was deployed during the pandemic, like in September 2020.
Okay, and a question to you both. We'll continue with you, Sarah, for the moment. Maybe it sounds a bit awkward in the context of how serious the work is that you're doing, but is there an achievement during your deployment that you're, on a personal level, the most proud of? What would you say that is, Sarah?
Yeah, for sure. There are many things actually that I'm really happy and proud of. I think we managed to put a lot of efforts to bring everyone around the table or online through Zoom, reaching out to as many actors as possible across Libya. We managed to create a community, to work together, to provide opportunities, to exchange experiences, to build a newsletter, for instance, for everyone to know what's happening around the mission, and in a very short period of time to do a mapping of services. That is quite difficult exercise when we cannot reach out and see people physically to actually have access to information. So yeah, many things that we're happy about.
Okay, good. And you,
maybe,
Teresa? Oh, go ahead, Teresa.
All right, thank you. I think just like Sarah, there's a couple of things that I'm very happy that I was in the two countries to support with. And one of them is that in Kenya, we're able to do 4W mapping to just know which partners are providing what services where. And from the 4W mapping, then we were able to identify gaps. And as a result of this, we ended up initiating a training to scale up interventions or to equip more people to be able to intervene. Working with refugee camps, the needs are immense. And I mean, even if we took this whole group over there, we would still not be able to meet the needs. So then how do we able to meet how are we going to be able to meet the needs? We are now training the locals and the refugees and host community members in the problem management plus intervention. Is highly scalable, and believe that with this we'll have a lot of food soldiers on the ground to be able to meet their needs. We were also able to really, from the 4W mapping, to link people with services. As one of the speakers mentioned earlier, people have issues, but they don't know where to go for services for fear of being called crazy or out of your mind or this and that. But being able to speak about it and being able to direct people where to go for these services and kind of normalize it made it very easy for people to seek services. And lastly, just MHPSS being spoken about in clusters of sectors such as protection or child protection and GBV, or communicating with communities to demystify MHPSS and also to kind of correct some of the misconceptions or misinformations that are being put out there was a very good achievement for us, and we are very, very happy about that. Thank you.
Good to hear. I did actually ask both of you just for one achievement, and you've given me 50, but you're clearly doing lots of great work. You can't pin it down. So thank you very much, both of you. Before we move on to the next panel about COVID response, there's a question that's come in from the audience for the panel. And the question is, how can this deployment mechanism be elaborated into a multi-donor mechanism? Perhaps that's something for Sylvie?
Yes, thank you. Yeah, I think we're always looking for other partners and standby organizations to also take up MHPSS deployments, because at this point we are the main standby partner facilitating these deployments. But it would be very good, and also to to be able to provide more support in this area if other partners and other donors will also step up.
Okay, thank you very much. That's it from the audience at the moment. Keep your questions coming in. Thank you very much, everyone. We're going to move on to the COVID response panel. Now, obviously, COVID has added a very significant additional layer of complexity in MHPSS response, and the efforts of the MHPSS community in responding to the mental health needs of those affected by the pandemic are part of a multi-sector fundamental change in how we all across multi-sectors, lots of different sectors, respond to crises. Dr. Fahmy, let me go back to you. As a WHO expert on MHPSS for COVID and co-chair of the Interagency Standing Committee reference group, what efforts have been made by the MHPSS sector to tackle COVID? And let's go right back to February 2020, and let's make it as concrete as possible.
Thank you very much. One of the things we all recognized was the high-level advocacy on mental health in emergencies. Actually, just before COVID-19 pandemic start and during the COVID-19 pandemic, summits, statements, policy briefs, calls for actions on MHPSS by UN Secretary Generals, head of humanitarian agencies, high-level policy makers, the endorsement of the World Health Assembly decision on this area of work. This was really helpful in getting mental health and psychosocial support at country level out of the shadows, and emphasized to country responders that mental health and psychosocial support is not a luxury, is not an add-on. It's a human right and basic need, an internal part of the emergency response. Also, we saw recognition for mental health and psychosocial support at country level. Statistics are showing that 89% of countries reported mental health integrated in their COVID-19 response plan, and 65% of WHO member states responded, reporting to a survey, reporting that they have multi-sectoral platforms for mental health and psychosocial support activated during the response. 82% of countries reported that they have at least implemented one activity for MHPSS in emergencies during the response. Also, the unity we saw in the MHPSS community during the response, with a wide range of resources developed jointly within the IASC MHPSS reference group very, very early in the response. And some of these resources actually were translated to more than 140 languages and available in accessible formats and specific tools tailored for mental health of older adults, of children, of adolescents, of responders, of carer, of teachers, and others. COVID also have advanced our approaches and specific interventions such as self-help, for example, by releasing a guide, doing what matters in times of stress, and also intervention guides for specific age groups, such as the Living with Times for older adults specifically, our first interagency resource targeting mental health of older adults. We learned also during developing these tools that innovation in response does not necessarily mean innovation in information technology. Innovation can also mean through tools such as highly successful children's storybook. Innovation can mean innovation in approaches where we reach communities, and it's not one size fits all, adaptation required for every community. However, what is really worrying during the COVID response is the effect of COVID-19 on services. Based on a WHO survey, we found that mental health services were the most commonly service reported as disrupted among all other essential healthcare services. At the time we call for scale up, 25% of countries reported to WHO that they have scaled back their access to service to community-based mental health services during the COVID response because of emergency reasons. These are alarming findings because the services that actually exist before COVID-19 were very limited at countries. And to summarize, some of the lessons we learned regarding mental health and psychosocial support response during COVID-19 collectively as an MHPSS community is that Scaling up investment in multi-sectoral mental health and psychosocial support, both financial and human resources, really crucial and needed. A structural change is needed in governmental mental health services organization, especially in the health sector and social sector. It's essential really to shift from currently heavily emphasis on institutional-based models into evidence and human rights-based community mental health services. And mental health integration and emergency response need to also be coined with mental health integration in preparedness and recovery. And finally, knowledge exchange to document what we did, the innovations during COVID-19 by all partners represent really an opportunity to scale up further similar approaches that can be adapted for future humanitarian and public health emergencies. Thank you.
No, thank you very much. Lots of very clear examples of the response of the MHPSS sector to COVID there. Some of the ones that stood out for me, I don't know what it was for you, Carmen, but that we forget the importance of the unity. It really brought the community together, MHPSS experts. Some of the innovations are not just tech, but also analog, the children's book. And you've got a copy of that here as well?
We got a wonderful My Here Is You that has been translated now to more than 140 languages. It's quite impressive. And we just, this is the second one. This is the edition for 2021 that has just been published. And of course, the support for the caregivers, for parents reading these books with the children. I can only echo what Fahmi was saying. My clearest memory of February last year is this amazing community, some of you colleagues here in the room and some
Only
listening.
some of them?
Only some of them.
Some of
those
the
who could. And everybody online coming together, like really working day in and day out, all the hours of the day to release materials and to support countries. It was very impressive.
Yeah, absolutely. Apologies if you can hear some sound. It appears that one of the fans has gone on here. Okay, let's move on to a new speaker. Clearly, lots of very concrete ways that we're responding, but ultimately, you can't do everything at once. You talked about it earlier, Carmen. We need to prioritize, and I'm interested to hear the experience of someone who represents an institution that is forced to prioritize just because of how many regions it's present in and how many organizations it has to work with. From the International Federation of the Red Cross and Red Crescent Societies, Dr. Eliza Chung. Dr. Chung, are you with us? Can you hear me okay?
Yes, I'm here.
Great.
Yes, very clear.
Okay, in terms of priorities, where's your MHPSS focus been when it comes to responding to COVID in the Asia region?
Well, yeah, actually since like January 2020, when the IFRC launched our first global emergency appeal, we have been like including MHPSS as one of the core response. And up till now, a total of 4.2 million people spread out in 27 different national societies in the Asia Pacific has been reached by MHPSS services since January 2020. And capacity building has been at the forefront in the approach to MHPSS during the COVID in the Asia Pacific region. We have conducted some survey among our staff and volunteers on pandemic fatigue, and we also have some specific thematic training. For example, the psychological first aid on vaccine hesitancy to be conducted with our staff and volunteers to respond to people who may be like vaccine hesitant. And different regions and different countries and national societies have been responding to the crisis in a very creative way, just as what Dr. Fahmi said earlier on. At the local level, for example, the Malaysian Red Crescent team, they have sent in trained staff and volunteers to the COVID assessment center to look after the people there and also to monitor their mental health conditions. In the Philippine Red Cross, right at the beginning of the COVID response, they already launched the nationwide MHPSS hotline, a 24/7 toll-free like a call line to help people address with the distress and concerns related to the COVID. And for example, in Nepal, the MHPSS team also sent in their volunteers to facilitate the suicide prevention campaign within the quarantine facilities. And all in all, I would say these are all a lot of creative means, not only the technical side, but also to think of how MHPSS can address to the public health concerns in a pandemic.
But everything you described sounds so worthwhile doing and effective. But how do you prioritize which MHPSS services get your attention?
Right. I think in different countries, sometimes the priorities or the context would be quite different. For example, in some countries, because the team, they are also involved in a lot of public health measures, then obviously they can like think about how to integrate the MHPSS and the public health response. In other situations, when like the mental health needs are more like stand out, maybe like a specific MHPSS hotline would be needed in the local context. Like from the federation, from our perspective, also in the IFRC Reference Center for Psychosocial Support, what we are trying to do is to enhance their local capacity in addressing all these needs using different means.
And let's bring it back to the Red Cross organization itself. You've got a peculiar way of embedding MHPSS really at the heart of the organization through the MHPSS policy and resolution. Can you tell us a little bit more about that policy and how it's impacted your response to the pandemic?
Yeah, definitely. The policy and the resolution that you just mentioned has indeed like set up the really good foundation for us to respond swiftly in the pandemic. Back in December 2019, just before the beginning of the whole COVID situation, during the 33rd International Conference of Red Cross Red Crescent, which was held in Geneva, we adopted a resolution on addressing the mental health and psychosocial needs of people affected by armed conflicts, natural disasters, and other emergencies. This resolution emphasized the importance of like early and appropriate intervention of MHPSS to prevent distress from developing into more like severe conditions, and also to help build a more harmonized, contextualized, integrated approach and holistic response to the mental health and psychosocial needs. And following this resolution, there's also a roadmap for implementation 2020 to 2023. It is to recognize the urgent need to scale up our collective response in MHPSS to address to the needs and also to support people affected by armed conflicts and the disasters. It helped guide and support our national societies how to put it into action and to highlight the steps that can be taken by the states and also within our movement. For example, like under this roadmap, we have like 6 priority areas identified. And in the priority area number 1, it sets to guarantee a basic level of psychosocial support and integrate MHPSS across different sectors. It comprises of including basic psychosocial support as a mandatory training component for our staff and volunteers. For example, like PFA, basic psychoeducation. And this is why capacity building has also been like one of the very important actions that different national societies have been taken during the COVID, that they really want to train up the staff and volunteers how to address to people distress and concerns, responding to MHPSS needs, even during a public health crisis. So therefore, like this is, I think it's just like time-wise, a very good coincidence, and also the policy and the resolution has set a really good foundation for us, so that we are able to like respond efficiently.
That's something that other organizations also do, this mandatory MHPSS training for staff?
I think there's a lot of diversity, and there's more and more recognition of the need of colleagues not necessarily from the mental health and psychosocial support sector to have basic knowledge on how to address these considerations. I think it's a growing tendency to have trainings. Yeah.
Okay, thank you very much, Dr. Chung. We also have Deborah Magdalena with us from IOM, the coordinator of the MHPSS Technical Working Group in Northeast Nigeria. Deborah, are you online and able to hear us, and can we hear you?
Yes, I can hear you well, Kenna.
Perfect. Tell us, what was the situation in Northeast Nigeria before COVID, and what was the scope of the work you've done since then?
So yeah, thank you, Kenna. The emergency context or the humanitarian crisis in the northeastern part of Nigeria is actually a complex crisis settings that mix of high security risks linked to the insurgency, or maybe people might familiar with the Boko Haram that created like millions of internally displaced persons living in the congested IDP camps. So there's a high risk of sexual violence and abuse, mixed with issue of poverty, malnutrition, and multiple disease outbreak like the cholera outbreak, Lassa fever, measles, and etc. It's before the COVID-19. So the crisis has major impacts for the overall living standards, impacting the physical and also psychological well-being of the individual living in this northeastern part of Nigeria, and also how they can actually have the capacity, the resilience with all this crisis and also all the condition that they have to face. So with already the existing challenging situation, so I can say at that time, I think since the last year when the COVID-19 hits, the COVID-19 increasing like another level of psychological distress among the affected population. There are a mix of like anxiety, fear, confusion, and also frustration among them because the uncertainty and also unknowing what really happened at the period. And also there's a high level of stigma. I think there's like really high discussion on this one, especially in the Africa context, very high level of stigmatization. And also there was a level of even like Corona house given to a house with any of family members with the COVID-19 positive. So there's actually like a kind of like situation that happened before with this complex crisis in the northeastern part of Nigeria and adding with the COVID-19. And basically our scope of work, the mental health and psychosocial support has been there since at the maybe early onset of the crisis. So basically as a humanitarian actors doing the MHPSS, we're supporting the governments of Nigeria to increase the availability and responses, especially in the mental health and psychosocial support, in particular to the internally displaced person, also with the returnees and also with the refugee within this area. Over to you, Kenna.
Thank you very much for that update. And I'm hoping and assuming it's what is it like now in the region in terms of the stigma? Let's say, do you really feel that that there's less stigma when it comes to talking about mental health?
No, in terms of like, of course, with the mental health is still like high level on that one, and also another COVID-19 with the stigma. There is a lot of communication engagement going on, and also with another awareness raising at that time and since like the last year and even up to now, there's a lot of efforts putting by the MHPSS actors. It's all about we know, I mean, like all the discussion about how it's important for us working with the community volunteers. Just an example, when the lockdown happened, there's a period of the lockdown in March 2020. It's actually like giving a really big hit and shock to us because it was really difficult for actors to go inside the IDP camps because there's really restrictions. So we understand that this is really important to work with the community, engaging with them. And they're the one as very important elements and components to dealing with all the stigma, the myth, and also the misinformation that's really going on that one. With the mental health, I can say is still going on as well. But then I mean, like the understanding is already there. The awareness activities like continues to happen, and then we really try to dealing with this kind of like misinformation, even social stigma.
I think it was also Teresa Terry who mentioned the importance of embracing the local community really as a resource when it comes to MHPSS. Okay, thank you very much both. I've got a question from the panel, and this one comes from the Director General at ECHO, Chiara Giusto. Justo. I'm hearing Justo. Okay, good. Thank you very much, everyone, for that collective naming effort. Chiara asks, have we learned how to adapt MHPSS activities during the pandemic to still ensure access to these services? I think there's been quite some discussion on that. Carmen, what do you think? Are you positive about the ways that have been developed to adapt?
We definitely have clarity, and there's been a big effort. There's some of the documentation that we developed at the beginning on the continuation of services that our colleagues have contributed to. What there's is a need to put the resources where those efforts need to be done. The idea is clear, the how is clear. We just need the resources to make it a reality.
Clear. The next question for the panel is from Dipali Pavagadi. What sorts of outcomes are tracked to understand if the increase in MHPSS services has been truly helpful? Tracking outcomes. Who would like to speak to that? Who do you think we should go to for that?
I would love to, but I'm going to ask Fahmi if he's with us in the panel, and he's a great advocate of tracking systems, especially for the funding, but also for the activities, and he can maybe comment on the monitoring and evaluation as well. Fahmi.
Indeed, thank you so much, Carmen. An extremely important question, and this classically was always a gap in our area of work, how to really measure the collective outcome of all the interventions that mental health and psychosocial support actors are doing in different sectors at a country level. Very difficult, especially in multi-sectoral areas, and when you want to focus not focus only on outputs and activities, but also on outcomes. Tool has been released recently by the IASC MHPSS reference group, where extensive work has happened during the past years, a tool on monitoring and evaluation of mental health and psychosocial support that include means of verification to help partners at country level to measure the collective outcome of their intervention. So while there are several research that was done either at country or in a small group of countries level, but now we have a tool actually launched this month by the IASC MHPSS reference group that we will continue to roll out with the MHPSS technical working groups during the coming 2 years that will enable us to specifically measure the collective outcome. And I hope if we can share through the chat function with our audience the link for the newly released IASC MHPSS monitoring and evaluation framework with the means of verifications.
Yeah, indeed. Thanks for that, Dr. Fahmi. And don't forget, everyone, the chat function is not just about asking questions and contributions, but also sharing links and connecting with one another. Yeah, let's move on. We're going to talk now about MHPSS preparedness. How ready to go are the coordination teams when crisis strikes? Carmen, earlier this year, there was an important development when it comes to MHPSS preparedness. Can you?
Yeah, very specifically for preparedness for public health emergencies like the one we are all encountering right now with COVID. So in this year's World Health Assembly, all countries passed on the new updated mental health action plan. And that is the same action plan the WHO had launched in 2013, but upgraded and updated to the current situation, and very specifically includes mental health and psychosocial support in emergencies and preparedness. And I think that's a very important moment. And also we are seeing more and more countries integrating mental health in their preparedness plans, for example, for humanitarian crises, for natural disasters. So when countries are preparing for potential crises, we can see now a greater integration of mental health.
Okay. Okay, let's move on to the panel itself. And for that, I'd like to introduce our next speaker, who is Marcio Gagliato, and he's the international MHPSS expert from Brazil. Marcio, you've been working for the last 1 to 2 years on building MHPSS leadership capacity in Latin American and Caribbean countries. You've responded to acute large emergencies, and now you're working on MHPSS in development contexts. What are the main differences, would you say?
Thank you very much, Ikenna and Carmen. Well, I would say that the main difference is that MHPSS preparedness offers an approach that says we must go beyond emergency relief and life-saving actions. And we should begin with mitigation and prevention that includes a combination of several aspects, including environmental, social, and economic aspects. One aspect in particular for developing context, I would say, is making sure that the current preparedness structures in the different countries, the national disaster agencies led by governments and or public policies, they integrate MHPSS approach intervention in their plans. But why that matters now is your second question, Ikenna. I would say that it's because we are witnessing a world of unexpected shocks more than ever. Epidemics, floods, storms, droughts, conflicts are related to all this. And unfortunately, we expect to have it more frequent and severe. That said, I would say MHPSS preparedness is not only about preparing for this road, but also preventing that it happen. Therefore, an important key message I would say is that MHPSS in this sense must also discuss some difficult questions, such as why this is happening now. What are the structural, historical reasons behind poverty, inequalities, and injustice? And this is part of, must be part of MHPSS agenda, and especially MHPSS preparedness agenda.
And if we focus specifically on growing the capacity of preparedness, you know, it strikes me there's so much work to be done, especially when there's an acute large-scale emergency. How do you then develop preparedness as well? Let's go to a new speaker joining us, who's working with IOM Iraq, Hatem Marzouk. Hatem, are you online with us? Yes, great. Maybe you can speak to the question I just asked. How on earth, when you've got your hands full with an acute emergency, how do you build preparedness capacity?
Indeed, you're absolutely right. In contexts like in Iraq, for instance, where we're dealing with chronic problems of weakened infrastructure, scarce resources, and then huge crisis happening on top, there needs to be attention to both aspects, really. And I think the experience of working in protracted crises like the one in Iraq have told us that it's really important to focus on several aspects of preparedness, but I believe most importantly on capacity building, dealing with the local human resources, trying to address the gaps in the information, knowledge, and experience, strengthening the points of strength that already exist and building on the resources available is an important mix. And in that, it's really key to look at working both with the governments and with the local organizations in order to best address the needs that come from the field. And that would also feed into the longer term dealing for the preparedness part.
Okay, thank you very much for that, Hatem. Our next panelist is Joshua Duncan, who leads the Mental Health Coalition in Sierra Leone. And of course, Sierra Leone was heavily affected by the Ebola outbreak and natural disasters. Joshua, are you online with us? Yes, great. Can we hear you? Can you say something? No, maybe if you unmute. Yeah, great, perfect. Famous 4 words. Please unmute yourself. 3 words. Joshua, what are the benefits of strengthening disaster MHPSS preparedness in your view? And do you see that the present, well, hopefully we're segueing out of it, but the COVID-19 crisis also as an opportunity?
Indeed, there are outstanding benefits, especially when a country like Sierra Leone, with one psychiatric hospital and the Ebola outbreak and mudslide and, you know, a lot of these kind of challenges are. We would realize, first of all, that if there is no system in place already before this outbreak, the impact would be very great. But because there was a coalition partnering with institutions like the University of McKinney, threefold benefits could be outlined for this session. The first is a strong workforce in place, with at least 21 nurses as mental health or psychiatric nurses as compared to only one psychiatrist before then, and 400 clinicians trained in MHPSS response, and placed in all the then 14 districts in the country. So there was already an active team in place to respond to the crisis situation. But also, it's also good to know that if a system as such is in place, another benefit could be the response would not just be there, but it would be adequate and will really show effect, evidence-based response that will prevent a worsening situation. So there was a timely response of the mental health nurses, both in the MHPSS community and treatment centers. And this was actually a salvaging point as compared to the rebel war when there was no response at all. And the third aspect is that the involvement of community and their knowledge around mental health also created a clear referral path, so much so that those complex situations could be moved forward. And when these three benefits came in place for the Ebola and now in Corona, we realized that the rates of emerging mental health problem was reduced as compared to the 10-year-old civil war. And that is basically because there is already an MHPSS system in place.
And how would you say MHPSS preparedness is linked to risk reduction and resilience?
Oh, of course, risk production and resilience. You would agree until knowledge is actualized, it could be dangerous. Let me be quick to point out what happened before. MHPSS came into existence during people like Carmen's presence in WHO working in Sierra Leone. For us, it was a concept that was so foreign until a clear understanding came in. And of course, what you think is what you can do, and you can do better. So knowledge informs right action. And this was actually a benefit that prevented emerging mental health challenges that we had during the 10-year or 11-year-old rebel war, because the right action was done. And another link is the role around community network and support system to prevent severe impact. Traditionally in our communities, listening is good, but honestly, it was not so much practiced as it was when the MHPSS system was brought in place. So we realized that community actors, the teachers and other key stakeholders, we are able to sit and listen to people speak out what they feel and the impact of crisis. And that onboarding process actually mitigated outstandingly the risk around developing complex conditions, and it was nipped at the bud. That was our two key issues that had the impact in terms of resilience building.
Thank you very much, Joshua. And you mentioned it there, and so did Marcio. Preparedness is often related to strengthening natural disaster agencies at country level, which is a government's primary responsibility. But how could the humanitarian community kind of contribute to strengthening that? Who should we go to, do you think? Marcio?
Thank you, Ikenna. I would say there are several examples we could give, very concrete examples. But I think it's important also to set a tone that I don't think the humanitarian organization should take the place of the governments in doing so. But we should take the seat in the process as an advisors, or even especially as a facilitator of process, not implementers in that sense. A kind of a top-down approach, but accompanying process and facilitating those processes in supporting the local structures in that sense. In which way? Well, advocating that MHPSS is a cross-cutting thematic area. So it's not only under Minister of Health or under the Minister of Social Affairs, but it is really integrating MHPSS across the different sectors. Also helping to build capacity of actors in terms of even in terms of exchanging knowledge, not building knowledge, but exchanging knowledge. And I do that often in the Caribbean region. I take just different countries because I'm in that kind of seat to help the different actors, and I put them to talk to each other and get examples and exchange the experience in that sense. And this has been very rich. And I think also the two other aspects I would concentrate here is, one, advocate that communities, they are at the center. They are the local communities are in the driver's seat in those processes and advocating for that. And the last question, as I said before, is also making the hard question of why certain situations happen in those places. And I do think, given our presence in the different countries, it's our ethical responsibility to make those difficult questions as well.
And Hatem, Marcio's got lots of experience working regionally. What about you, the Iraqi context, the sort of wider regional context? How do you go about building the political will to make sure that governments are on board?
Right, I think that's a very important question, and I think advocacy is key in this area. So working with different countries in the Middle East and North Africa, it's really important to strongly advocate for prioritizing mental health and psychosocial support on the agenda. And in many countries, especially those with fragile contexts or different other challenges, it's really hard to push. But I think it's really important to consider that MHPSS is a very versatile domain where there are different areas that could be integrated in other aspects as well. So as Marcia just mentioned, it's not just about mental health or the Ministry of Health's work. And some of the examples of the work that IAM has done in Iraq, for instance, is working on integrating MHPSS in other areas of response, generally within the humanitarian, but also within the development context. And I think this is sometimes very appealing to the government. So we've been working on integrating MHPSS in livelihoods, supporting the government in developing its first national suicide prevention strategy, which involves different stakeholders from different ministries in the government. So I think it's really important, again, as Marcia mentioned, to look at the communities as the driver of change, but also have strong advocacy tools to advocate at the level of the government to prioritize mental health and psychosocial support and address them in the best possible way through the lens of the domain that we're working in, not just from one side, which is providing mental health services.
The domains, can you sketch out what is the character? What's the difference in MHPSS preparedness across those different domains? So humanitarian, development, peace building and public health emergencies. What's the character of MHPSS preparedness in those different domains?
Right, so borrowing from the famous IASC pyramid of layers of intervention, I think each of the domains that you mentioned has its very specific priority or character. So for instance, in public health emergencies, there would be a certain surge in the need for more specialized and focused interventions. In peace building and community engagement domains, we need to work more on strengthening the family and social supports. So I think, as I mentioned earlier, being such a versatile area of work, MHPSS can easily adapt into the priorities of those different needs. And it's really important, while designing a response or while designing an intervention, to look at the different tools that MHPSS has. So, for instance, working in Iraq, there's a lot of focus now on peace building, community stabilization, and this is one of the things that IAM is working on very actively in Iraq. So it's really important to build on the skills that the MHPSS has to support the government in its efforts. And this is a classic example that we're working on now, involving the returns from the camps from Northeast Syria in Al-Hol to Iraq and all the surge response that is involved with this return. And it's kind of a classic example of a chronic situation where there's an acute crisis happening on top of it. Over.
Thank you very much. Let's go to our audience. There's a question that's come in here, and it says, as Marcio says, crisis is the new normal. What is being done to break down separations between MHPSS and new ideas on integrating social and psychological services? So what's being done to break down separations between MHPSS and new ideas on integrating social and psychological services? Let's go to, well, your name's referred in the question, Marcia.
Thank you, Ikenna. It's an interesting question, but I also must react on the statement of this question that Marcia says crisis is the new normal. Though we see all those events happening more often, and we do expect that this is going to happen more often as the way that things are going, we cannot normalize that crisis is the new normal. We cannot, and we must resist in that sense. And actually, the MHPSS field should be one of the first voices to shake the structures if we start kind of normalizing somehow, or we see normalizing statements about crisis around the world. One aspect that I would say that to avoid the separation inside of the field, I think this is one of the great contributions in the MHPSS, the mental health and psychosocial support humanitarian field, contributions to the narratives or the discourse or the technical sides of mental health and psychosocial work around the world, because it does create a space, and it's the consequence of a long-term discussion, putting together different knowledge and understand the different knowledge space and functions and the places in emergency response. So that is, I think, is one of the biggest contributions of the MHPSS sector, and I do see that as a bridge builder in different contexts where it is divided. It's divided as health separated that, or even some knowledge inside of mental health itself that are divided with other parts or technical approach in mental health. And the MHPSS really helps to build that bridge because it offers the pyramid, for instance, the different layers, and understand that everyone must work together, and everyone needs to be aware that its own work has an impact in the well-being of the population. Therefore, this is not an area for a specific knowledge or a specific profession, but invites every single actor, including, of course, the community, because they are the protagonists of that action, to understand that what's in their role is going to impact the well-being of their own population and their own action. And then we rephrase or we restructure the way that MHPSS is offered to the community.
Very clear. Thank you very much for those powerful words. And thank you to all of our panelists now. Okay, we've done a lot of talking. A lot of ideas have been shared. Now, I'd like to share a video, which is a little bit echoes the words of Marcia there. A reminder of why we all do the work that we do when it comes to MHPSS. It's a look back at a performance of Ahmad during the Mind the Mind Now summit in Amsterdam in 2019. Ahmad grew up as a Palestinian refugee in the Syrian refugee camp Yarmouk in Damascus, and from the age of 5 he learned to play the piano, first at the conservatorium, the conservatory music school in Damascus, and later at the musical faculty of the Baath University in Homs. During the Civil War, he literally, spoke to him about this, transported his piano via a pickup truck from location to location to play for children, to bring a little bit of happiness into people's lives. And performing on public streets and various institutions in Yarmouk. While you listen to his story and his music, I would like to invite you to think about the following question, though. How has the upheaval caused by the pandemic over the last year affected the mental health and psychosocial well-being of you personally, at home, there, and here in the room? How's it affected you and your loved ones? And what systems and support structures helped you during the crisis?
عرف حالي أيام أحمد مخيم اليرموك. صارت هي الأغاني اليومية اللي بتتحدث عن معاناة الشباب والأطفال والصغير والكبير في مخيم اليرموك، فصارت هي مغنات.
بيسألني استركوني شعبي وخلوني بيوزعني فضموني.
يرموك يا يرموك هنا عند منحدرات التلال نفعل ما يفعل السجناء، ما يفعل العاطلون عن العمل. نربي الأمل ونحصي شهداءنا 70 60 و100، ونحصي جرحانا 200 300. هنا دمشق، هنا دمشق. تنام الضباع على جثة امرأة فتفرش أحشاءها وتغطي بها بردا. هنا دمشق يا أرضي يا أرض الياسمين. نتغنى بدمشق ونقول 5000 سنة. يوما سأعود إلى هناك. Hey Please. Keep it running. When I read the paper, what I have it here, I give you, Adrian, 5 minutes, 2 minutes before. I am a speaker. I don't know what I should to speak. Anyway, it's a big pleasure for me to be here. And music is very, very important. It's helped me a lot and still help the people in Yarmouk, in Syria. We try. I don't have UN support. I don't have UNICEF support. I try with my own, with my piano, with my destroyed finger. I lose it in the bump and also my face. And I try. I don't know. Maybe one day I will succeed, at least to make less trauma for me. I can sleep without destroying my body with concert. This is what I do every day. I can sleep at least. Maybe I will try to have at least 2 children without trauma, without pain. This is what you feel and you see when I play piano. Maybe one day I will be pianist, how my father planned for me to play Mozart and Tchaikovsky and Rachmaninoff without thinking about what happened in Syria, without thinking about my brother, I lost him, I don't know, he's still alive, not alive, without thinking about Nira Saeed, without thinking about Mahmoud Tamim, they killed in the present. But I will think about him every time. It will not change. But at least I will try. And it's a big pleasure for me to be here. Thank you for all of you to sing with me.
Wow. Now, Dutch audience participation very clearly lacking there, but very powerful speaker he is, and musical piece, very touching. So I hope you all kind of enjoyed that. I don't know if enjoyed is the right word, but appreciated that performance. Okay, we're going to move on. Just a reminder to everyone at home to please send in your contributions and questions using Slido. Don't forget, just go to slido.com and enter in the code 880399. Carmen, I asked everyone to consider that very personal question.
Yes.
How's your mental health fared over the last 18 months? And we spoke briefly before. I said I was going to ask you personally, and you said, oh, I don't know if I should tell, really share the real experience. Tell me.
No, I think we've all felt it in one way or another. I'm, like many others, living in a country that is not the country where my family is, and then that meant that you couldn't see your loved ones, and you were isolated in your home alone. We were talking before about the massive work effort that was done last year, of the insane amount of work, and sorry for the word. So of course that has told, and I think at some point, I had this conversation with many of my dear colleagues and family and friends. This is tough. But I think the nicest thinking for me was, but I'm in a great place. But I'm surrounded by resources, but I have access to services. I have means of communicating with my family online and seeing faces. And it definitely gives you an incredible understanding of how privileged we are in some countries. And for me, the difficult personal experience, which I have to acknowledge, my mental health was affected, like many of us. It gave me a renewed willingness to work on this sector, because it immediately makes you think there are so many places where there's no these systems, where there's no support, where there's so much difficult to access specialized and family support because of communication or other ways. So the tough time that I think to many of us meant, yes, we're doing the right thing and we want to continue doing it.
Okay.
Yeah.
Thank you very much for sharing.
Thank you for asking.
Okay, we're now going to talk about the minimum service package for MHPSS, a tool under development by 4 different organizations, WHO, UNICEF, UNHCR, and UNFPA, and that's intended to guide MHPSS actions in health, education, and protection. Carmen, what is the minimum service package, and why is it across those different sectors?
I think, and this is a good opportunity actually to maybe, because this summit is diverse. Is the Amsterdam conference was very humanitarian action focused. We have more of a diverse audience here, and I think maybe this is a good opportunity to actually explain why have we kept on saying mental health and psychosocial support MHPSS, and this is because for us in humanitarian response to mental health, we see the urgent need to always make sure the mental health and psychosocial support happens across all of these sectors, that you can't achieve the well-being of the communities affected by crises if we only do mental health from the health point of view, or we only do psychosocial support from the protection, for example, side of things. So we have to maintain it together, and that means that we have to integrate our work. We can't, it's not us doing MHPSS, it's us integrating MHPSS in health, integrating it in protection, integrating it in education. So tools like the minimum service package, which gives an orientation and an idea on how to do that, how to actually do your mental health activities inside of each of these sectors, I think are really, really important.
Okay. Yeah. And we're going to hear more about those tools with our next speakers. Yeah. Joining us are the 2 people who've been working on this project for the past 3 years, so it really is their baby. Inke Weisbecker from WHO and Quiver Nickabaird from UNICEF. Welcome, both of you.
Thank you for having us.
Great. Well, I'm going to give you the floor for the next 5 minutes because you are going to give us a short PowerPoint presentation and perhaps also a video of demonstrating this in effect. So please take it away.
Yes, exactly. Thank you, Ikenna, and also thank you for Carmen for the opportunity to present this important meeting. We will now provide you with a brief overview of the mental health and psychosocial support minimum service package, which is quite the mouthful. So MSP in short. We can go to the next slide, and we don't have many slides, actually the one before that. So we're very grateful to the Netherlands Ministry of Foreign Affairs to support the MSP project. The project has really evolved over time to actually include multiple funders, partners, and different areas of work. So starting with the Netherlands funding health and child protection components of the MSP, then the UK government and Education Cannot Wait have come on board to also include the education aspect. And lastly, UNHCR has also mobilized funding through the Global Protection Cluster to also include general protection and gender-based violence aspects as well. So the MSP project, as Carmen already mentioned, is actually a real opportunity for us to work together more closely across different sectors, which we hope will ultimately lead to better collaboration and implementation of MHPSS programs and scale up. And now we just want to show you a brief video which illustrates the need for the MSP, explains what it is, and also includes perspectives from our colleagues in the field from Nigeria and South Sudan. So if now somebody could play the video, that would be great. Over.
The number of people affected by humanitarian crises is at a record high. Armed conflicts, natural disasters, and public health emergencies like COVID-19 cause widespread suffering and seriously affect people's mental health and psychosocial well-being. Many people affected lose everything they care about: their loved ones, homes and livelihoods, their communities, their sense of place and sense of self. Yet resources for mental health and psychosocial support services are severely lacking. This leaves many people in severe distress and without the care they need. More than 85% of people affected by mental health conditions in humanitarian settings do not receive treatment. Where services do exist, they are often disconnected and inconsistent. Service providers often lack the training and support they need to provide safe and effective services. Humanitarian donors often don't know which MHPSS activities they should fund, and those planning and implementing programs are faced with tough decisions about what to prioritize. The MHPSS Minimum Service Package outlines the minimum MHPSS activities that should be implemented in all emergency settings across health, protection, and education sectors. The package is based on existing guidelines and extensive consultations with people involved in humanitarian assistance in frontline, regional, and global roles. It is designed to support humanitarian actors to improve coordination between different sectors, identify MHPSS program gaps and priorities, provide timely MHPSS programs based on evidence and guidelines, increase funding allocation for MHPSS, improve coverage of MHPSS activities, and ultimately improve the mental health and psychosocial well-being of people affected by humanitarian crises. The MSP is currently being piloted in Colombia, Iraq, Ukraine, Nigeria, and South Sudan.
We in WHO in the Northeast team are very happy that the minimum service package on mental health and psychosocial support is coming on board, because this will set the tone and will make things clear in terms of advocacy, in terms of coordination, in terms of integrating mental health and psychosocial support, in terms of training the frontline health workers, what specific interventions, and these guidelines, we are so proud to be part of it. Again, this will give the WHO the opportunity to guide partners. As a minimum service package, we believe that this is what the state can use and ensure that all primary health care services are integrated with this. People with gender-based violence who need support, people with all forms of challenges because of the ongoing insurgency of more than 13 years, and it has brought this humanitarian crisis to the people with a lot of stress, and challenges. We believe that the minimum service package is the right time.
Currently in South Sudan, we are in the process of updating the 4Ws assessment to map the MHPSS needs and resources in the country. The MSP will be a great contribution to this exercise. We will understand more in terms of prioritization of needs. We will contribute more effectively to humanitarian needs overview, humanitarian response plan, or humanitarian appeal funds. I think the MSP in the context of South Sudan will be more than instrumental, will generate more evidence. And also currently we are in the process of developing the National Mental Health Strategic Plan of South Sudan for the upcoming 5 years. The MSP will help us also to understand more what to do and what is working, what is not working.
We are hoping to increase coverage of MSP activities with increased funding in humanitarian settings around the world. We are now seeking feedback from diverse humanitarian actors. You can log in to explore the MSP and let us know your thoughts. With support and collaboration from humanitarian actors around the world, the MSP can play a key role in helping people to recover and rebuild their lives after an emergency.
Great. So I'm going to jump in now and tell you a little bit about how this package was developed, what it looks like, and how you can actually help to improve it. So this slide here gives you an overview of the process of how the MSP was developed over 3 years. The first year of the project focused on developing the content through literature reviews of key documents in MHPSS, in health, education and protection, particularly child protection and gender-based violence areas of responsibility, as well as broad humanitarian guidance like the Sphere standards. And these literature reviews were followed by lots of consultations through global networks for MHPSS and development humanitarian clusters and AORs. We had more than 100 participants in interviews and focus groups, and we really aimed on including diverse people based in diverse emergencies, people frontline workers in emergencies, as well as regional and global advisors. And so the first draft was developed based on these literature reviews and consultations, and then that draft went through multiple rounds of peer review and revision to produce the field test version that we currently have, and that's now publicly available. And so now we're in the field demonstration or pilot phase, and this involves inviting colleagues globally to read and use the MSP and provide us with feedback, as well as working more intensively with colleagues in the 5 countries that were mentioned in the video there. So we're working with colleagues in these countries to implement components of the MSP and to learn from rolling it out in practice. And then after this pilot phase, which will last about 1 year, we will revise the MSP again to incorporate the lessons learned from these various sources. And basically, we're trying to get as much feedback as we can to make the tool as relevant and useful as possible to people, so that we will launch a really relevant version towards the final version towards the end of next year. We can just go to the next slide, please. So what does it look like? Well, the field test version is available in 2 formats, as an online platform and as a downloadable PDF. The online version is a little bit more comprehensive. It includes lists of guidelines, standards and tools to support the implementation of each minimum activity, as well as additional resources like guidance on using the MSP in public health emergencies like COVID. There are also some videos on there, like a virtual tour of the platform and an introductory webinar. The PDF was designed to be slightly shorter to keep it to a more manageable, printable size, but there are links throughout that bring you to the relevant section of the online platform. And basically, we encourage anyone who's interested to log on. It's available there. You can register to browse the MSP and then provide feedback so that we can, like I said, make the final version as impactful as possible. And anyone who registers on the platform will receive a link to provide feedback via a survey in a couple of weeks. Go to the next slide now. Here's the final slide. So that's just been a very quick tour of the MSP. and we're very happy to have been able to introduce it here at the summit. I'm happy to answer any questions that you might have, and we also welcome any follow-up questions or queries that come up a little bit later. Our emails are available on the screen there. Thank you.
Thank you, both of you. I must say, very smart video you have there. Illustration super clear, right? Yep. Whoever's making your videos, let them make more, I think. Okay, yes, we do have some questions. The first question comes from the audience online, and it's: how is the MSP different from existing documents and guidelines? For example, how's it different from the Interagency Standing Committee guidelines?
Yeah, thanks. The MSP really builds on the existing guidelines, including the IASC guidelines, the SPHERE standards and the Child Protection Minimum Standards, GBV Minimum Standards, the INEE Minimum Standards in Education. So it draws on and aligns with all of these existing standards, and also some upcoming resources like the IASC MHPSS Coordination Handbook, the M&E framework that Fami mentioned earlier. So some of these great resources that have been developed in response to COVID as well. So a lot has happened in the 14 years since the IASC guidelines were published, and they had a huge impact on defining the field and promoting a real growth in MHPSS across sectors. And the principles and activities in the IASC guidelines are as relevant as ever. But in recent years, we've seen a proliferation of many different types of MHPSS activity, and they are meeting critical needs, but they can look quite different in different locations and different sectors. And it can be quite difficult for people planning and funding programs to know, looking at this wide range of activities, which are really the most impactful and which should they prioritize for their funding and for their programs. And so now that MHPSS has really grown to meet the needs, the MSP aims to help donors, coordinators, program planners to really prioritize from this wide range of MHPSS activities across sectors, which are the most impactful in emergencies. And so, yeah, it also helps to kind of provide a common language across the different sectors, like Carmen was mentioning earlier, to help people understand what MHPSS looks like in different sectors, what are the aspects that are common across all the sectors, and how can these different types of activities complement each other to have a comprehensive response that meets at least a minimum level of quality, no matter where you are and what emergency you've experienced.
I think you should go into politics. This is a very diplomatic answer. Basically, you're saying the IASC guidelines are a bit old and dusty. This is a new, improved version. No, of course not. They're still relevant. They're still relevant. Okay, but listen, I like what you're saying. You know, common language sounds very good, but people are also a little bit stubborn. They can be stubborn. Is there a danger that the MSP could be seen as too prescriptive?
I think, first of all, just to definitely say this is very much coherent with the IASC guidelines and very much builds on and grows from that work, and they really are central to what's in the MSP. What's the question? Sorry.
Too prescriptive, too top down, this is it.
Oh yeah, Inka, I'll let you have a chance to speak.
Yeah, maybe I should, I can say something on this as well. Yeah, I think definitely we do not want to be too prescriptive. So we have to find a balance between providing much needed direction, but also being open to different contexts in different countries. So we've all really made an attempt to make sure that the activities and the associated actions are very general. Things like providing supervision, technical oversight, all of these things are very important and really apply anywhere. At the same time, we also are looking for feedback over the coming years. So if there are any things that people feel like that doesn't really apply to us, or this is missing, or this needs to be added, or anything like that, we're actually will be improving, revising, and updating the MSP by the end of next year. So now is really the chance to give feedback, but the goal is really to have something that is general enough to always be applicable over.
There's no real danger of people seeing these as the very minimum, that this is what the minimum that we have to do, because you'll keep revising, you'll keep reflecting on what this what the minimum is.
Yeah, and I might add there that the MSP includes the minimum activities, but it also includes what we're calling additional activities. So you have your core set of minimum activities, but then there are additional activities that, depending on your context, your resources, and the needs that you're seeing, you might say, oh, well, in our context, these additional activities are actually, absolutely essential, and we want to prioritize those too. So while the whole purpose was to kind of make the range of activities a bit more manageable by putting some sort of priority order on them, it's absolutely not the intention that any response would stop at the minimum, and there are kind of clear pointers for what you might consider next in the additional activities.
Okay, great. Thank you both. We have to move on with the program, but it's been really good to see and hear about the progress of the MSP. Okay, when we gathered a couple of years ago, the focus of MHPSS was on crisis response, and since then the structural integration of MHPSS has been evident in a broader sense, and UN peacebuilding architecture. The UN peacebuilding architecture review was used by the Netherlands to help connect MHPSS more strongly to the humanitarian and peacebuilding communities and expertise. Soon several organizations started to embrace that effort, and in this section we'll find out why and how. First, through a pre-recorded message from Professor Mike Wessels of Columbia University about why MHPSS is so important in peace building. Then from Ananda Galapati, a long-standing MHPSS expert, sharing a variety of examples of what MHPSS in peace building may consist of. And lastly, Frederica Bubenza, a long-time advocate for bridging MHPSS with peace building communities. She'll briefly explain what's happening globally and what's happening globally now to enable operations locally.
Hi, this is Mike Wessels. I'm from Columbia University, and it's a great pleasure to be able to speak with you today, even by video. We're here to think about the historic task of integrating MHPSS and peace building. This integration is really important because although the fields have evolved along separate lines, in fact, they're complementary, and work to integrate the two is really necessary for achieving the full potential and impact of either one. And I want to emphasize that this is a bi-directional integration that's needed. Following armed conflict, you have lots of people who've lost homes, been displaced, had their identity assaulted, suffered gender-based violence, and live in economic deprivation. And these count as grievances that can fuel future conflicts and ongoing animosity. And I think that in order to achieve peace building, we need to build in an MHPSS element that deals with these and reduces these tensions. We know that people with PTSD, for example, are less likely to support peace building processes. But it works the other way as well. If we think about after an armed conflict and the task of reintegrating children who had formerly been recruited into armed forces and groups, what we find is in multiple countries is that they may be asked to reintegrate back into communities that have combatants, ex-combatants from both sides returning to communities. Community people live in extreme levels of fear and insecurity, and that damages their mental health. And in that context, it can be really important to include peace building activities such as dialogue groups, building social trust, enabling cooperation and reconciliation that simultaneously advance peace building and promote mental health and psychosocial well-being. Currently, there's a great need for guidance on how to integrate MHPSS and peace building. There are two important initiatives underway. One of these is led by Raksha Sule and myself on behalf of the IASC reference group on MHPSS. We are currently, just this week, launching a global survey that I hope you'll participate in, and also some country-specific learning that will enable us to learn from and engage deeply with primarily youth and women who are oftentimes creative actors at grassroots level. And we'll be developing some guidance and suggestions on the way forward later in December. And then we'll be sharing these in January and February for revision, consultation and revision regionally and globally. The second initiative, no less important and, like I say, complementary, is led by Frederica, who of course is on this panel, and her distinguished team. They are the pioneers and long-term leaders in this field who've done amazing mappings and literature reviews. Their survey for UNDP is a little more focused perhaps on what are the supports and resources that people who are trying to integrate MHPSS and peace building need, and how are they relating with donors. So these two are ultimately complementary, and we are collaborating and working to ensure that our recommendations are aligned and converging. But, you know, thinking beyond these two important initiatives, this is a longer term process, and it involves the work of everyone. I sincerely hope that you will join hands all together and work in a spirit of openness, co-learning, and collaboration to all do our part to strengthen the integration of MHPSS and peace building. Thank you very much, and best wishes for a highly successful conference. Thank you.
Thank you very much. I think we're going straight on to the next video.
It's actually live. So greetings to everyone from the east coast of Sri Lanka. Like Mike and Frederica, I'm a strong believer in the importance of linking MHPSS and peace building work, and would like to quickly share with you some personal experiences of what that has looked like across different phases of Sri Lanka's 30-year war, including the last decade of its post-war transition. I hope that these examples can illustrate some of the diverse and significant ways in which the fields can support and serve each other. So as a young practitioner during the active conflict period, I witnessed how state psychiatric services and community activists work together sensitively to provide humane care for survivors of sexual violence, torture victims, and also sometimes deeply damaged perpetrators. And in doing so, preserve trust and lines of communications between polarized communities and structures, even at the worst of times. I also saw how creative therapeutic work with children from brutalized communities through safe spaces like a peace garden offered opportunities to blunt hate that was rooted in terrible experiences, even whilst attacks and recruitment of child soldiers continued. Living and working in conflict-affected communities over decades, I also experienced the profound benefits gained from just a couple of years of relative safety because of a formal peace process or ceasefire. The relaxation of checkpoints, the decrease in violence, and consequent reduction of fears and stresses of daily living had a really tangible effect on the well-being of communities, reflected at both the social and individual level. The dividends of even temporary peace very evidently include mental health, which I can also personally testify. But Sri Lanka's peace talks collapsed, and our war did not end through peace, but by battle in 2009, with terrible human losses. In the decades since then, it's not been easy to heal either the suffering of the survivors or the deep divisions in our communities, but it has become clear that both these processes must often go hand in hand. In 2015, when a national consultation on reconciliation was held to shape policies and institutions to deal with the legacy of conflict, MHPSS practitioners like myself were involved in designing the process in order to minimize potential harm and also build in support to distressed survivors as they testified. Submissions by both survivors and practitioners to this process recommended that psychosocially sensitive procedures and access to MHPSS services be central in the creation of formal reconciliation structures, including an office on missing persons and an office on reparations. The recent national reparations policy includes significant reference to psychosocial support as a direct result of this. But the role of MHPSS in helping people to deal with the past is not straightforward. Some victims refuse professional counseling because they fear it might erase the pain or memory that bears witness to injustices and losses, and thereby undermine their quest for justice. The form of psychosocial support needs to be appropriate and sensitive to the politics of conflict. Whilst they may not access formal structures, families of victims do draw on trusted social and spiritual resources in their quest for truth and accountability, and these can also provide frameworks of meaning and support that help them to endure and manage the pain of loss. I see local women's groups striving to build connections between neighboring villages that are implicated in past atrocities against one another, and which still can be flashpoints for new tensions. And note that much of their work is actually about processing grief, managing difficult emotions, and providing interpersonal support. They don't call it MHPSS and peace building, but that's what they're implicitly doing. The integration of MHPSS in processes that enhance social cohesion can also be more explicit, like in the case of contact-based interventions to bring school children together across historical divides, where teachers have benefited from training on adapted psychological first aid methods to manage distress that sometimes arises in these encounters. I hope that these examples give a flavor of how the two fields of MHPSS and peace building intersect in diverse ways, and also perhaps highlight how they can both benefit from documenting such examples and sharing the underlying principles and practical lessons of what enables meaningful integration and collaboration.
Sorry for thinking you were pre-recorded. You're very live. It's good to hear from you. Okay, let's go to our final speaker, Frederica Bubenza. Are you with us, Frederica?
Yeah. I'm also very live. Greetings from Cape Town via Berlin to everybody this morning. And yeah, thank you to Mike and Ananda. I have to say that it's just such a huge privilege to work so closely with people who are passionate and committed, and also people that you really like, which makes this work just wonderful. So when my colleagues Marion Tankink, Yvonne Sleep and I co-hosted an Inception conference through the Institute for Justice and Reconciliation in South Africa, where I work, and the then War Trauma Foundation, which I'm sure many of you remember, in 2015, to explore whether linking MHPSS and peace building resonated with practitioners and academics from around the world. Spoiler alert, of course, because the response was a resounding yes. We didn't think that traction would be gained quite as quickly as it has. A lot has been achieved in a really short period of time. And for me, this has always signified how incredibly urgent the linking of mental health and psychosocial support and peace building is. Mike and Ananda's really powerful inputs highlight to me how the integration appears to be a no-brainer. And this is something that comes up at a lot of meetings that all of us are in, where people are saying, but this is such a no-brainer. How is this not already happening? Surely the one field can't achieve sustainable outcomes with the other. But the truth is that the two fields are still working largely in isolation from one another, both at a policy level and often in the field. And that a lack of knowledge, widespread stigma, and limited institutional support is actually preventing us from joining hands. Still, it excites me hugely how quickly progress is being made. Looking back at the 2015 conference that IJR hosted, we conducted a mapping study and a literature review. Kindly, Mike referred to mapping studies and literature reviews. It was just one of each. Enough work nonetheless to begin to build an evidence base around why integration is so important. So we created a small expert group, of which Ananda was already a member, from around the world, which was formed, which found that sustainable integration needs to happen through a co-created approach that brings together practitioners from both fields, ideally at the local level and from the very outset of projects, to jointly craft a praxis that respects the advances, builds on the overlaps, and uses the strengths from each field to respond better to the long-term needs of conflict-affected individuals and communities. Operating in contexts of high direct and structural violence causing extreme levels of stress on a daily basis, our MHPSS and peace-building partners in countries like Zimbabwe, South Africa, Kenya, Uganda, and elsewhere have long recognized the need to link the fields and responded to this proposed co-creation methodology with a lot of enthusiasm. That their experiences and recommendations were then successfully fed into the 2020 Peacebuilding Architecture Review, which the Ministry of Foreign Affairs of the Netherlands process contributed to, building important momentum. Important multi-level efforts around the world continue to create and to contribute to this momentum and to the budding community of practice that is emerging. As such, the work of the Interagency Standing Committee Working Group on MHPSS and Peacebuilding, where conversations and webinars about integration have been held between leading international agencies, has been really helpful. Similarly, the important research and advocacy work driven by local and international NGOs around the world to build a largely new body of knowledge is really important. So is the recognition by the IASC and the UN Development Programme that consultation-based guidance needs to be drafted to begin to guide the way forward. And Mike has spoken about the work that him and my team are working on. And most importantly, and Ananda has referred to this as well, the critical work being done by local NGOs from Zimbabwe to Lebanon to Uzbekistan, who are already practicing what we call integrating MHPSS and peacebuilding, but hasn't been documented and formalized sufficiently. So much more needs to still happen to operationalize integration, more South-South dialogue to enable cross-pollination and exchanging of best practice, more research into existing structures and supports to prevent imposing external, largely Western notions into contexts that have their own ways of rebuilding conflict-affected communities, more conversations that bring funders into the arena, and more advocacy that counters the very harmful stigma around MHPSS in most parts of the world, and which has an impact on us as peace builders who want to bring that work into the work that we're doing. So in my view, and to conclude, there's no peace without peace of mind. And the sooner we realize and action this, the better. Thanks. Back to you, Ekena.
No, thank you, Frederica. Thank you, Friederike. I'm sorry.
Beautiful. Yeah, they all work.
Okay. Thank you very much. Also for highlighting the cultural sensitivities there and the importance of South-South dialogue. I think we'd all love to see more of that. So great. Thank you very much. Okay, we're going to move on to our final panel session, which we have to zip through, unfortunately, but it is a very important one nonetheless. It's a look ahead. What do we need to concentrate on for the coming period? And we're going to do that and find, explore how we build on the experience of the momentum that was created back in 2019 in Amsterdam and what's ahead next year in Italy by exploring 4 recommendations. And these are sort of collectively, I guess, created but initiated by the Kingdom of the Netherlands and the IASC. I'll introduce the speakers in just a second, but what are those recommendations, Carmen?
Very briefly, those that can be found in the same infographic that we were showing at the beginning, and they're very basically focusing on funding allocation for preparedness, for response and for recovery, on staff and volunteers' care and well-being, very importantly, capacity building, so we have more experts, and cross-sectoral use of MHPSS. Those are the 4 recommendations.
Okay, clear. To help talk about those, we have from ECHO, Ms. Joanna Darmanin, who is Head of Unit for Humanitarian Aid and Thematic Policies. We have from the Ministry of Foreign Affairs in Denmark, Ms. Mette Thyssen, who's the Head of Department Humanitarian Actions, Civil Society and Engagement. And from the Ministry for Cooperation in Germany, the Deputy Director General and Commissioner for Refugee Policy, Dr. Elke Löbel. My first question is for Ms. Darmanin. MHPSS is now explicitly mentioned in the EU communication on humanitarian aid. Can you tell us how can donors help crisis-affected populations by moving from commitments to concrete implementation?
Thank you, Ekena, and thank you for giving me the floor to give you a little bit the ECHO perspective. As you rightly point out, the communication on humanitarian action that was adopted this year sets out a strategic framework for humanitarian assistance in the upcoming years. And there it clearly states that the EU will invest in policy development and quality in a range of thematic areas, including mental health and psychosocial support. As you mentioned, funding is important. So just to give you an idea of funding by DG ECHO on MHPSS, from 2019 to 2020, funding for activities in the field of MHPSS have increased by 18%, from 18.7 to 22.1 million euros. This funding stems from a demand that is based on needs assessment and gaps identified in the provision of services. So you can see that the demand is growing and the funding has to grow apace. But it's not only about funding. The policy framework and its development are equally important. So, for example, DG ECHO is currently appraising proposals under the Enhanced Response Capacity envelope in order to support actions aiming at reinforcing MHPSS at a global level. And in these programs, the idea is to present concrete tools and approaches that can be replicated with tangible outcomes for beneficiaries. From a donor perspective, I would like to share with you and with other panelists some concrete actions that can be taken in consideration for the future. First of all, I think we need to converge our efforts in exchanging views on what we mean by quality MHPSS in crisis situations, because we need to build a common framework when we speak to our partners and translate these policies into action. Secondly, for us, it's important to avoid creating parallel or standalone MHPSS activities, which can be detrimental to the existing fragile systems and would not be sustainable in the long term. For us, the preferred approach is to conduct strong needs assessment in support of existing systems to the extent possible. Indeed, integration is a key issue for us, and to integrate MHPSS services within the health system at all levels, especially at the primary healthcare level. Other sectors as well are relevant and need to be integrated, such as protection, gender and education. And this is the approach that we follow in DG ECHO in terms of a multi-sector approach. Also, I think it's important that we support the ongoing process of testing the services package, which we've just heard introduced and explained in some length in the previous segment. And it's important that this tool can help partners, practitioners, and decision makers to identify the most important MHPSS activities to be provided in low resource contexts and obviously their costs. There is clearly still much room for improvement on MHPSS, especially in terms of identification of the gaps and provisions of services that are context-based, the building of strong referral systems for the most severe cases in need of specialized care, capacity building for partners and also for implementers, and clearly the reinforcement of national and subnational systems for sustainability and ownership. Just before I conclude to answer this question, our thanks also go to the IASC MHPSS reference group for providing us the up-to-date information on developments within the sector and to bring it together. Yes?
Thank you very much. Sorry to interrupt. I just have one very brief, because I want to move to the other speakers as well, but I like the sound of the 18% increase you mentioned in terms of funding from DG ECHO, but the type of funding is also important. Are you already making core funding available, for instance, which is something that a lot of people are calling for?
Well, yes, core funding, it depends what you define as core funding. Indeed, our approach is to have MHSPP integrated within the context of the other sectors that I mentioned. But indeed, for example, for referral of services, for capacity building, etc., those would be going directly to the area.
All right, thank you very much. Let's go to Ms. Thyssen. At this Paris summit, the focus is very much more on health, on MHPSS in MHPSS in a health context rather than humanitarian context. What experience can the humanitarian sector bring the world, as it were, considering the crisis that we face, crises?
No, thank you, Ekena. And thank you also to the IASC MHPSS reference group and the Dutch Ministry of Foreign Affairs for organizing this workshop. Maybe I should just highlight 3 priorities on why and how Denmark worked to promote MHPSS in humanitarian crisis, and what experiences we might contribute on that basis. And I think the first point that I would like to make is about focus and prioritization. In this case, on focus on the protection of the most vulnerable, because in our humanitarian support, we are obliged to focus on and protect the most vulnerable. And if you suffer from serious mental health issues or mental trauma caused by conflict or disaster or gender-based violence, psychosocial support and protection mechanisms are life-saving and crucial for the ability to take care. And this is why we have made MHPSS a focus area in Denmark's humanitarian action, and as set out in our new strategy on development cooperation, which we just launched. So focus is the first priority. And secondly, I think our experiences on partnerships. As a humanitarian donor, Denmark works through strategic partnerships with civil society organizations, with ICRC, UN, and also ECHO, where we just had Joanna. They do an incredible job to promote mental support in often challenging contexts, and most often in close partnership with local actors. And I think the video message that we had from Professor Mike Wessels, he highlighted the grassroots level, and I'd really like to second his perspective. The partnerships combined with localization and capacity building of national actors. These are essential in order to ensure timely support for people in need. Community-based approaches have in many contexts become a proven modality in the lack of mental health specialists. Third and last element perhaps is that we should really turn to the youth. The youth can really be accelerators within this agenda and other agendas, and I think we should utilize their resources, both within and outside the humanitarian sector and the health sector, as you pointed to. Children and youth experiences and knowledge and engagement should be the center of designing and implementing and evaluating the responses to the mental health and well-being. And that's really crucial for the efforts to be relevant and effective in humanitarian response, but also in the health sector. So I think, again, to sum up, you asked what experience we might bring to the table as humanitarians. And I think the 3 points that I just tried to make would be the focus on prioritization, the partnerships, particularly with the local level and local responders, and finally, as a third element, building on the resources of youth. So I'll leave it at that for now, and thank you so much for giving me the opportunity to speak.
No, thank you very much, and especially also I think highlight that last point about youth. It's certainly something I know in the Netherlands is a Youth at Heart summit, and it's there's a real focus on including the youth in decisions that affect their lives, and I haven't heard it talked about so much, but in this particular session. But I know there was another workshop completely devoted to that. So yeah, good to hear you talking about that as well. Thank you. Let's move to Dr. Löbel. From a German perspective, Dr. Löbel, how do you think we can amplify existing efforts to increase MHPSS capacity and identify opportunities for accelerating progress?
Yes, thank you very much for this opportunity to talk about the issue. I have been listening the whole time very carefully, and I have participated in different events in the Amsterdam conference, which really helped to bring the issue into the focus of international cooperation. And so I hope you allow me to answer your question, but focusing on some findings I found out while listening to the experts. I'm not the expert in MHPSS. I'm a representative of a ministry for economic cooperation and development, and I think I'm a practitioner, and I also worked some time, we're in charge of Sri Lanka, so some of the inputs I would like to reflect. So first point I would like to make is the networking is functioning. After Amsterdam, we also had a Syria conference, and we had a forum in Geneva and so on. So go on doing that. If we want to increase capacity and accelerate, we have to network in international community, in international conferences. This would be one finding I would like to mention. Secondly, COVID-19 really brought us to show again how the impact of COVID, for example, on the socio-economic situation, on crisis acceleration worldwide, also triggers the necessity to work on MHPSS, which also is a result of all this. But, and this is a message from a government representative, we have to have stronger evidence on what we do and in how far it really works. So look at evidence. This would be another point for me to accelerate our capacity and also our impact. As BNet, just to mention this shortly, we anchored psychosocial support in our multi-year crisis response, which is important, multi-year, not only short-term. Under the special initiative on displacement, for example, we finance more than 60 projects, and we cooperate with international and within UN organizations with NGOs. This is another point. Cooperate, coordination, network with different actors. I would like to mention the Netherlands here and thank the government of Netherlands, not only sorry, for the Amsterdam conference, but also we really work together. We exchange ideas and information. Next, for me, I would really like to stress the inputs of Mike Wessels and Ananda from Sri Lanka. We have to accelerate and to broaden the support of for MHPSS. We have to look close to the nexus between humanitarian aid, development assistance, and peace building. I think if you ask me where is the future intervention field for MHPSS, I would say this is the one. Also triggered by COVID-19 and the climate situation, which might trigger crisis and where we need MHPSS intervention, not only on an individual base, but on a community base. So I think there is a field where we have a lot to do. Michael mentioned reconciliation experiences we have, and which we could also use to show what we can do in this sector. And if we work on the nexus humanitarian and development assistance and peace building, I think there is also the point where we come to a scaling up and showing successful interventions at local level. We have to really have a close connection to the local level and know how how the whole thing works in practice. I don't know whether there will be the possibility to mention another point because we are running out of time. So there is one thing I really would like to mention, perhaps as a last point. From my experience, and I'm working in the field for quite a long time, we really have to find more people for the MHPSS agenda we are following as a big network, and I congratulate everybody here that this network is really existing and we feel the dynamic which this network has. Don't forget to listen to the voices of people in the center, because if we really make understood also in policy shaping what we are talking about, who are we working for? I just give you an example, Yazidi women in Iraq. There are a lot of examples where Yazidi women really, by support of MHPSS, by trauma work, etc., care society. These are examples we need also to show to people who decide, who shape policy, to make understood what is this all about. And it's not only about the one Yazidi woman, but it's about her community, where we hopefully will have a future for the Yazidi community. And last point I would like to make, looking at Afghanistan, the current situation in Afghanistan, I think we should really, really work very intensively on MHPSS with NGOs, stakeholders, to understand better what is going on, and again show that MHPSS can be a good support for people in need. So sorry that I already mentioned perhaps the future points, but I wanted to make clear what are the points from my perspective. Thank you.
Very much appreciated, Dr. Lobo. And I think if people take just one thing away from this workshop, and I hope they take lots more than that, but it's those 4 words from you, Dr. Lobo. The network is working. You know, COVID has been a setback, but the network is working. I think that's really powerful. Okay, I don't know if our speakers have time for one more question, but I do have one more, which I'd like to put to each of you, is how do we get more stakeholders on board to push and implement MHPSS across all sectors? Maybe just one idea from each of you, if you have time. First of all, Mette, Ms. Thusen. What would you say?
No, thanks a lot. I think what we need to do is just to continue the efforts. I think we need to stress the success story where it actually worked, and then continue the advocacy efforts as has been doing, particularly taking the lead from the Netherlands and France. I'm sure then we will get the rest on board. Thanks.
Thank you very much. Ms. Darmanin?
Yes, I would say that it's a couple of points that were raised by Germany. I think we need to continue with the systematic collection of data and to show best practices, because there are good examples out there which we can build on and we can showcase. I think it's the Nexus approach. So the idea of having a Team Europe initiative, which we are trying to explore with the Netherlands, etc., will hopefully make these links between humanitarian peace and development. And also, I think it was a point raised by Germany, the need to support the evidence base, because that is where we can show and guide implementation for the future. Thank you.
Thank you very much. Dr. Lobo, are you still with us? Perhaps one final thought as to, how do we get more stakeholders on board?
I'm still with you, but somebody stopped my video. I'm sorry, I cannot make it visible again. I would repeat my point, and sorry for the video. It's not my technical influence here. I would state again the point, make the voices of people we are working for visible, in a sense that everybody can understand what all this is about. I just would like to refer on the pianist. I was part of the audience that day. So make this clear, get more people support MHPSS who do not understand what this MHPSS is all about. They will if they listen to the voices of the people. Thank you.
Thank you, all of our panelists. Carmen, a final word from you. What do you think? Are you happy with the workshop today?
I'm extremely grateful, very, very happy. It's been, for me, very, very insightful, even though I work on this every day. Yeah. I still learn and I still listen to really relevant comments. I'm extremely thankful to you as well for guiding us through. And thank you to everybody for being with us for those 2 and a bit hours.
Yeah, indeed. And that brings us brings this session to a close, everybody. Thank you very much for joining. Thank you once again to all of our panelists, all of the experts. There's more than enough cause for hope in all the insights and reflections that we've heard. So my advice to everyone here in the room and everyone online is to take some time to reflect, recharge, and then get to it. My name's Ikenna Azuike. Thank you very much.
Thank you so much. Bye.
Bye. Thank you. Bye, everyone.
Thank you. Bye-bye.
Bye-bye.
Bye.